Good morning again, colleagues in ministry. I'm delighted to be a part of this training process this morning, and I hope that you're all well and that you're all encouraged and empowered for ministry, the ministry set before you today. It is my prayer for all of us that we will be very successful today in our lives and in our ministry responsibilities. I'd like to just a few seconds share a little bit about myself. I'm a veteran of the United States Army, having served honorably for 20 years and 4 months. Started my ministry in 2004 and began healthcare chaplaincy in 2007, and almost immediately developed an interest in palliative care and had a sense of calling to palliative care. I served as a chaplain in a Catholic healthcare system in Kalamazoo, Michigan, for 6 years, Borges Medical Health, and 3 of those years I served as the palliative care chaplain, first palliative care chaplain for that hospital team, and I participated on a national study and project which was intended to develop best practice for palliative care with the intent in mind to provide a chair, as we said, a chair at the table for the chaplain, where the chaplain is not just a silent observer, but someone who contributes to the care plan. I've been a part of VA system since 2014 with a fellowship in San Antonio in palliative care. And I've been a part of the Houston team here since 2015. Married to my wife, Nancy, for 32 years. She's also a veteran. I'm an ordained minister of the Seventh-day Adventist Church, and I'm endorsed by Adventist Chaplaincy Ministry. My presentation this morning is intended to introduce the specialty of palliative care with emphasis on the chaplain's role in providing care. As you may have noticed, the presentation is titled Working with Pain and Dying, which is what we often find ourselves doing, our role when we come to this particular area of specialty. We do go until we have 60 minutes, right? Well, you said yes?
Yes, we do. We have 60 minutes.
Yeah. Okay, or less. All right. Trying to get smart here. Okay, there we go. There we go. Some stated objectives this morning, and I'm sure that there's several of you on the line. Do we have some folks this morning who are working in palliative care right now and have some experience in working in palliative care? Yes. Good. And whether or not we are assigned as the palliative care chaplain, we still find ourselves, I believe, from time to time. Yes, plenty of folks are involved in palliative care, but we still find ourselves, whether we are assigned as the palliative care chaplain, still responding to patients, veterans who are in palliative care. Some objectives this morning is to define hospice and palliative care, the goals of each discipline, and the chaplain role, providing care in the midst of pain. The chaplain's role in providing care in death and dying, and share some brief case studies. It may just be that we will just share one study and introduce the family bereavement survey. So this is an introduction to palliative care for some of us, and I'm sure that we might be able to pick up something that we hadn't considered before. And I invite you, if there is something that you want to share, please do that. Begin with, I'm using an old computer, and so forgive me here, I'm hitting enter, and okay. We'll begin by talking about what is hospice care. Hospice care is comfort care provided to the patient and their family if they have a terminal condition. As you can see, less than 6 months, I think this is from the VA's site that deals with, under the geriatrics, you might be able to see the website down there, talks about when you're in palliative care, of course, you know, individual is no longer seeking treatment other than the palliative care. Hospice care can be provided at home.
I'll down here if that's the next step, so you can kind of see.
I'm sorry, I didn't hear you. Okay, maybe that wasn't for me. Hospice care can be provided at home, in an outpatient clinic, or in an inpatient setting. This is from the National Hospice and Palliative Care Organization. Hospice care focuses, adding some more, hospice case focuses on the pain, the symptoms, and the stress of serious illnesses during the terminal phase. The terminal phase is defined by Medicare as an individual with a life expectancy of 6 months or less if the disease runs its natural course. Under the Medicare site, if you want more information about hospice care, under the Medicare site, there is further information provided with various criteria that affects all VA patients who are eligible receive hospice care without any cost. Whereas on the outside there are different criteria, but some of the all of the medical care. I'm sorry, I'm trying to get caught up here with my. Am I the only one moving the slides?
Yes, Sherlock, you are.
Okay. All right. Let me do something I'm pretending that I don't need. So let me do this for a minute. So the Medicare sites, the Medicare site provides some further information about hospice care. Christy, I might have to relinquish. I might have to relinquish control back to you and ask your forgiveness because it's not advancing for me.
Okay, that's fine, Sherlock. Oh, I'm sorry. That's fine, Chaplain Brown.
Yeah, no, that's fine. Maybe it's because I'm using an old computer here.
Okay.
Could we go to the slide that says the goal? Okay. I guess I'll just have to say next slide.
That'll work.
Okay, and so as you can see in hospice, the goal is to allow people to die with dignity and support. And if you had an opportunity to take the TMS course, it provided much information about what that kind of care looks like. Much can be said about dignity. We're not going to get philosophical about our presentation this morning. I simply say this, is that for an individual to die with a sense of value, knowing that they are loved, knowing that they are worth the time given to them, believing that the care and the attention being provided, especially at this time, the end of life for them, is coming from a place of compassion. I think dignity is for the patient to have within themselves, to be filled with, and then that dignity is provided via the support that we provide to the patient. The next slide, please. The best outcome for hospice care is achieved through a team approach in order to meet the full needs of the patient, which, again, we are well aware of all these areas of chaplain. We know this quite well. the care that we provide, the spiritual care that we provide impacts all these areas. We provide some care that impacts the physical, emotional, the social. And while we are generalists, I learned in palliative care a while back that while we're generalists in providing the other care, facilitating the other care, but we are the experts in providing the spiritual care to the patient or the veteran that we support. Next slide, please. Hospice care is provided by an interdisciplinary team that is led by a physician, includes the nurses, social worker, chaplain, volunteers. We have hospice haze. Here we have, and some of you might have the program where we have No One Dies Alone volunteers who spend time with the patient. You know, some of you who had an opportunity to take the TMS course, there's an interesting statement made there that says that the nurse is the quarterback on the interdisciplinary team, that the nurse is the quarterback. I am not going to pretend to be a sports, knowledgeable of sports, but I thought about it. I want to ask the question, if the nurse is the quarterback on the interdisciplinary team, what position or what role do you imagine that the, and I'm really asking this really for our contribution and learning, what you see the chaplain's role to be if the nurse is the quarterback? Any thoughts, any feedback on that? If anybody had a chance to do the TMS course, or even without it.
This is Philip Williams in Santa Clara, Palo Alto, excuse me, in response to your question. The first observation that I have that comes in your definition, hospice care is provided by an interdisciplinary team that is led by a physician. I don't ever recall the physician taking charge of the interdisciplinary team. I know he's the key figure, that's for sure. But when you talk about the nurse's role, I think that the nurse has her role, as does the chaplain, as does the social worker, etc. And I think that far too often I've seen the chaplain taking the back seat on the interdisciplinary team. And so I think that there's equal responsibility. Sure, we're in a medical facility sometimes, and the physician is providing the medical care, but that does not put he or the nurses fully in charge of that. I have run the interdisciplinary team meetings for years, and giving everybody their individual responsibility.
Yeah, thank you for that. And I think that's the uniqueness of especially palliative care. If you imagine that table really being sort of a round table, really, because all the providers are really are vitally important. And so with a round table in mind, then I guess with the round table in mind, there isn't anyone that sits you know, necessarily as head of the table. Thank you for your contribution. I see some of the feedback being provided. Thank you so much, sir. The next slide, please. And various settings for where hospice care can be provided. Working out of HBPC, I think I have provided care to the veterans in all these settings, maybe except out of a group home. Others may have, but next slide, please. So now we talk about palliative care. Right away, I love it when that is drawn, that the differentiation is made that palliative care is not hospice care. It does not replace the patient's primary treatment. It works together with the primary care, with the primary treatment being received. It focuses on the pain, the symptoms, and the stress of serious illnesses. It's not curative treatment, and you yourself might have noticed a couple of times when you hear that someone is in palliative care right away. I've even seen physicians or even nurses who are not working within the arena of palliative care. Sometimes somebody might immediately say, I didn't know that this person was dying, or it's not hospice care. I like to consider, in my explaining palliative care, and maybe you have a model too and explain that, I like to think of palliative care as this big umbrella, and then hospice care as the smaller umbrella under palliative care. Next slide, please. Another thing for hospice care too, it might simply be just described as supportive care, because individual can still continue to receive their treatment and follow a treatment plan under the palliative care. It's an approach from the World Health Organization. It's an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention of relief of suffering by means of early identification, assessment, psychosocial. That's the World Health. Palliative care can start at any time during the illness of the patient. However, the earlier an individual is in palliative care after receiving a debilitating diagnosis or illness, life-threatening illness, I think that they are better able to cope with their illness. And something else about palliative care too, it's studies have shown that palliative care tend to extend the lives of individuals who are maybe within a hospice context, but it certainly brings relief to people who are suffering emotionally, because one of the first things that stress is reduced for a lot of people who are, once they enter palliative care in an ideal situation. Unfortunately, what I see oftentimes is that in palliative care, most of the patients that are in palliative care are almost always, oftentimes, hospice patients. So they enter both services at the same time. That's been my experience. Palliative care has changed a lot over the last 10 years or so. There are whole facilities that actually provide clinics. All they do is provide palliative care. And one of the hope discussed in the past, especially in this project that I was working on, is that palliative care patient would be referred to the team much earlier in their illness, which will help them along. But sometimes, I don't know whether it happens so much in the VA, but some doctors who are not palliative care necessarily boarded or certified, they tend to wait for a while before they provide that care. Before that, they will make the referral to the palliative care team. Palliative and hospice care is part of the end-of-life care plan. I'm reading a note. Am I right to think of them in that way? It is, but a person can certainly be in palliative care and not a hospice patient. And I think we have a few slides coming up that I think it will be referred to. We will talk about that. The next slide, please. Palliative care brings relief from pain and other distressing symptoms that people have. It's not intended to hasten or postpone death. It integrates the psychosocial and spiritual aspects of the patient care. I tell you, well, I won't jump ahead of myself. The next slide, please. It offers a support system to help the patient live as actively as possible until death when folks are in an end-of-life situation. It offers a support system to help the family cope during the patient's illness and in their own bereavement. I believe that in some respect, palliative care prepares the patient for hospice when they have a need to go to hospice, if they need to receive such care, because oftentimes it's people are distressed by the physical pain as well as emotional pain that they are going through. And later on, I think after we talk about the goal, I will pan that out a little bit more. The next slide.
I did. Do you want me to keep going?
Yeah, the next one, please. Yeah, such as so it's applicable early in the course of the illness in conjunction with other care that's being provided. It matters to me and to you when our specific needs are recognized and being addressed. And I think it also matters to the patient when their concerns are addressed by their care team. Once I visited, and probably more than once, but I'm thinking recently I visited a very angry patient who vented that they're not listening to me. How many times must I say the same thing over and over? He says, I feel like killing myself and hurting other people, and different doctors keep coming in and asking me the same question over and over again. How many times can I say this? Do they think I've changed my mind when I first said that? And that's frustration, and that's pain, that's suffering. And something similar happens to patients when they are seen by outside of multidisciplinary team, when people have various comorbidities, and they are maybe even in the VA context, probably a lot of times when people have several chronic illness, COPD, chronic heart failure, and maybe even cancer diagnosis, they make a lot of ER trips because they're seeing different providers, and they can't have this treated because of this illness, because of the heart, and so they live under a lot of stress. This person is managing this care, this care over here, and this person is, and they seem like they can't get everybody together on one page. You have to make several weeks with different providers before you can get to a place of palliative care tends to bring all of that together by the palliative care team, making the coordination with the various providers to deal with the patient's the pain that they're having. And when people enter the palliative care,
Oh no.
when people enter the palliative care,
I'm so sorry, Sherman. Hold on a second. I mean, Sherlock.
it's okay.
Yay. Okay.
That's okay. I'm not in the ER here very much, but just a quick example of that. And I don't think the VA is probably much different, but what I see in the hospital where I was in Michigan, you have people with the illnesses that I described. They would make trips to the ER sometimes once a month because of anxiety and because, of course, if you've got COPD and you've got these distressing symptoms and you can't breathe, you're going to be in the hospital. You're going to be in the emergency room. So we have people that are constantly, maybe this week they're here for this week they're here for that. And over time, when that individual now enters palliative care, you see that their visits to the ER is not as frequent because now their symptoms have been managed, and they are aware of have more education. Palliative care also provides more education about what's going on with the patient. The next slide, please. The Center to Advance Palliative Care talks about, again, it is to relieve the symptoms and to improve the quality of life for both the patient and the family member. And it's appropriate at any age, at any stage of the illness, and it can be provided along with all other medical treatment. Palliative care team improves quality of care in a manner that leads to reduced hospital costs. And in just for information's sake, sometimes palliative care in hospital system outside of the VA, I mean, it doesn't make the hospital money, but it certainly, what it does is, as it's supposed to there, it reduces the cost of the hospital. As I explained to you before earlier, when that individual stopped making all those frequent trips to the emergency room because their symptoms are being managed, then certainly it helps the hospital from having to spend costs to run all these tests when the individual needs are being provided for. So their costs, they're saving while they don't generate fund. Next slide, please. Typically on the palliative care team, you'll notice if you are part of the palliative care team, it's different in other teams, in that in other IDTs that there's more time devoted to the family in the palliative care team. In an ideal team, there's more time sitting with the patient to understand, having a conversation, which is something that really doesn't happen in other because in other IDTs, because you know, most of the time it's just looking at the patient's charts and moving. In an ideal palliative care team, time is spent in conversation with the patient about what matters to them as individuals, and you know, what matters to them as a family, with the team present, with all the various providers who can hear their concern, hear the desire of the patient, their hopes, their dreams, and then could help to formulate a care plan to meet the needs of the patient. Skill communication and what to expect in the future in order to ensure the care is matched to the goals and the priorities of the patient and of the family. Now, my brother who spoke earlier and shared about leading the IDT with the and the chaplain leading out. I think in a well-established team, as we said earlier, it's not anyone could really introduce the concept of palliative care once you're working with providers that you have been with for some time, and because you're trying to, again, solicit from the patient, trying to find out from the patient what matters to you. And anyone can lead that conversation. Next slide, please. The expert symptom management of both physical and emotional distress. And again, I think as chaplain, we touch on all areas, all these areas. And again, we are the expert. We are the expert. We're the generalists in providing those other cares, but we certainly are the expert in providing the spiritual care needed. And again, the palliative care team will also close the gap with the patient and the family by coordinating with other providers to streamline that care that the veteran needs, so that it lessens the anxiety that they have, so that they don't have to meet with the palliative care team and then another provider that is, everything is handled under the palliative care care team. I've been going, I've been galloping away. Any thoughts so far?
please feel free to put your comments in the box or to turn your mics on and offer some thoughts and feedback to Chaplain Brown.
I've been in the hospital for some. Yeah. No input. Well, we'll continue to move along. How about the next slide, please? Palliative care is not time limited. You know, oftentimes you'll find individuals, additionally individuals who qualify for hospice service and who are not emotionally ready to elect hospice care could benefit from these services. And I'm sure you have experienced it before. If not, you certainly will, that sometimes the team believe that this patient, this veteran should enter hospice care, and certainly that's a decision for the individual to make. But as you know, sometimes some individuals are not ready to accept their terminal diagnosis, and some people, as they say, as they should. You know, again, it is their care, and some people want to fight for a while. I'm going to fight this illness. I'm going to do this. I'm going to do that. I'm not going to give up, because they believe if they enter hospice care that they're giving up. And so you do find some people will, before fully committed to hospice care, will enter the palliative care when they're facing an end-of-life situation. Next slide, please. Again, the settings for palliative care is pretty much the same as the hospice setting, except you have clinics, you have facilities that actually provide hospice care, and that's all they do.
Chaplain
Yes.
Brown, I don't know if you see Patrice's comment, but what is one way that a chaplain as a palliative care and hospice chaplain could help families that are in denial of their loved one's terminal illness and that are maybe in that phase of grief?
Yeah, and you know, that's a challenging question, because you certainly don't want to pull someone along into making any decisions that they don't want to. But some ways that in my experience, and others certainly can share what they have done, is having a what chaplains do, having a sit down time with that, either the patient or the family member, to see what it is, how do they understand their diagnosis and its prognosis. Because sometimes, and here's another way too, that the chaplain can be very helpful by being there when they're given the diagnosis in technical medical terms and such. If we understand, or when we understand what's being said, after the team has left and we visit with the patient, oftentimes I can say in layman terms, because I didn't go to medical school, what I've heard. It's a lot of information, and so sometimes, even though the patient heard it, the family heard it, they have different interpretation. And so sometimes I try to find out from them, what do you understand? How? And then I say, well, I heard, where it's appropriate. And some people really just want some time. So it's just really walking with them and seeing what they understand. And if you need to have the doctor come back, or anyone else in the team, to provide them further information to help them understand that. And then other times it's just take time. Anybody have something to add to that?
Yeah, Chaplain Brown, this is Chaplain Prentice from Salt Lake City. Can you hear me?
Yes, sir.
Yeah, I was just going to say, I liked your comment there. We called them a family care team meeting, and it includes the palliative care social worker and palliative care doctor. What they've been doing before I got here was just taking the family in, Well, the family has all these questions, and a lot of times they don't feel comfortable asking those questions, because some of them are quite extensive, like, do they qualify for hospice care now? Or, what do we have to do to get them qualified? And can we take them to a facility? Do we have to have them at home? All these little things. And then when they're giving these diagnoses, they don't know what it is. So having the chaplain present during that is an adjustment that we made here, because we're not a disinterested third party, but we are a third party. And it's okay. We can ask, hey, doc, what does that mean? Or,
Exactly.
what benefits are they entitled to when we put them on hospice? So it's something that other chaplains might consider if they're not already doing it.
Yes, thank you for that. Yes.
Here's another question. Sometimes patients don't want to see chaplains because it signals they're at the end of life. So as a hospice and palliative care chaplain, how would you work with that?
Again, there is no one answer to say, okay, this is how you do it. But some of the ways that I've handled that is, until you're there before the patient, if it's a patient that you have a relationship, maybe you're just meeting the person for the first time, they may need an education on what it is that chaplain, the ministry that chaplain provide. Certainly not so much in the VA. I mean, I've had people in the VA, as you might have, patience, presence, gentleness, certainly. I've had people say, I'm not dying, I don't need a chaplain. And people really sometimes don't know what it is that that chaplain, the services that chaplain provide. And if you come from, I just had someone called a few days ago and was making arrangement for her father who is in hospice, and she's making some pre-funeral arrangements. And she says, first of all, my father is not religious at all, and I'm sorry, it was her grandfather. It is her grandfather. He's not religious. I want to honor that, and yet I would like a chaplain at the National Cemetery to be there, to be present. She says, are you able to be there without doing religious talk and this and that, because my grandfather wasn't into that. And I think if we can, maybe I'm stepping away from the question, because I was just going to say, in that case, what I have told her, we certainly can be there to say words that honors this individual as a veteran. But I see some response that are yes. Yeah, basically at the end of the day, we're gonna end up do what we do best, and that's listening to the context. Yes. I'm a spiritual friend on the journey. Yeah. Sometimes I joke with folks, say, I promise I won't baptize you. I'm not going to do this. And yeah, so there's a number of things that we can do. Thank you. Thank you. The next slide, please. And the goal of palliative care is to improve the quality of life for the patient, the family members who are threatened, who are being affected by the life-threatening illness. And again, what does that look like? For some individual, we can't determine what the quality of life look for. For some individuals, it may be something that we might look and say, is that all you want to do? It's going to differ from individual to individual. And so that's determined from having that early conversation with the veteran and their family to know what's important to them. The next slide. Yeah, the next slide, please. Yeah, the best outcome of palliative care is achieved through a team approach. And we have stated, we spoke to this. The next slide, please. pain is the main concern for hospice and palliative care patient. As a member of the IDT team, the chaplain has the responsibility to help. I don't know. I certainly, as a member of the ID team, remember I said we're all generalists, and so we certainly can, when we enter the room, we have to be, and I've seen it here on the, through our presence, through listening, we want to be able to, when we walk in that room, the second point down there says, talk about ground. Maybe I should have had that, but be grounded and be centered before ourselves, before we enter the patient's room, because we're entering this sacred space that we really don't want to carry anything into the room per se, more than what the what is going to be important and valuable for that patient. Because sometimes when we walk in, I've walked into a room and you can see that this person is in pain. I mean, we can ask the question, are you in pain? And we certainly can ask the question, you get a response, ask the pain level. What is your pain level? What are we doing with that information? Have you told your nurse that you're having this pain? And sometimes I've had patients, veterans say, no, I don't want to bother them. And then as a member of the care team, I can let them know that, hey, this person is in pain. He says his pain is a 9. And then it might not be, it might be, we have the chart there. We certainly can, we can share that with the team, because again, we are concerned. And then the spiritual care that might be the spiritual care that we provide. And so that's why we can't hold on to an agenda. We have to move on and maybe not visit the patient right then, be considerate and provide the most immediate need of the patient. Come back later if that physical pain is too intense, and get the help that the patient needs. The next slide, please. That's, some of you might have seen this little booklet here. It's called Primer of Palliative Care. If you don't have it in your office, generally the palliative care team or doc will have it. It's from, and you can also, I think it's under the American Academy of Hospice and Palliative Care Medicine. Talks about pain there. The next slide, on chapter 5, it talks about there's a whole section devoted to the spiritual and the existential needs of the patient. It's an interesting, I think you would find that useful, valuable to see, because these are things that the palliative care doctor or nurses or other providers, psychologists on the team, that they may pose to the question. They're also doing a sort of spiritual assessment too. So it'd be very valuable to see some of the, we don't have the time. I see I'm running out of time, but some very valuable questions on hope and values and relationship. Again, finding out what's meaningful to the patient. So if you can get your hand on that booklet, try and do so. I think you'll be well pleased with the information provided. The next slide, please. Again, the chaplain is the expert on matters of spiritual care. Listen, allow the conversation to happen. Give voice to the patient. Respect, validate, hope with the patient, advocate. The next slide, please. Just a simple diagram there to show sometimes at some point in the care, your role might intensify at times. And while I think the chaplain is unique in that while other providers might stay close to their lane, sometimes the chaplain, being the advocate, may have to work with these various other parties to ensure, again, that the needs of the veteran, the patients, are met. You might have to, in advocating for the veteran, maybe you might hear the team saying something that the patient might have shared with you that you might find valuable, that contributes to the care, because as you know, people will tell us things that they don't always tell other providers. This is the first time I'm telling someone this, and if you know that it will help their care, please do that. Then the next slide, please. I just put that picture up there. I thought it was a kind of a, certainly in the 4 chaplains, I think they were all of that. They were all of that. And that's what we become, especially on the palliative care. As a member of the palliative care team, we fill all those roles at some point or another. I just highlighted something about the 4 chaplains, just one sentence that says, through the chaos, the pandemonium, 4 men spread out among the soldiers, calming the frightened, tending the wounded, and guiding the disoriented towards safety. Sometimes we find ourselves as chaplain filling that role and trying to help the rest of the team to say, hey, let's stay focused here. We know this to be the needs, the desire of the patient. Let's stay focused on this particular area. The next slide, please. We want to provide that care that the patient's been getting now that the person might be in hospice or in palliative care. And again, just emphasizing those goals. Hospice, allow the person to die with dignity and support, and being reminded the goal of palliative care, improve the quality of life for the patient and the family member. And we don't get to determine the quality of life per se. I remember my director of the hospital in Michigan, she shared how it was that this family just really, this patient wanted to go home and to die with his family. And upon visiting the home, social work and I don't know who else had visited, but they didn't deem the home fit for a sick person to be. And because it was, how'd you say, a lot of hoarded type conditions there. And so they didn't want to let this family to go home to die, but that was how the family lived. And so the chaplain had to come on board and say, hey, this patient is dying. This is their home. Might not be where we would live, but then the chaplain entered that area of advocating, because the quality of life for this person was improved by being with the family member, with the people who love them. And so again, sometimes as chaplain, we're advocating for things that might not seem to make sense to people, but it's patient-centered care. Next slide, please. Just simply put, I think it's important to, again, I didn't go to medical school, but it's important to have an understanding of the diagnosis, the prognosis, and so that if we don't, I think for me, it helps me to better understand the patient when I'm with the patient, so that they don't have to say certain things. And sometimes patient asks me, you are aware of my illness? If I know, I say yes, because and then they pick up from there, and that's helping the individual along the way too. And some people, especially in my experience, again, I've come to realize that people with certain types of cancer, it's sort of embarrassing to get in a discussion to tell you where I've got a cancer, and so it kind of helps us so that we don't even have to go there. We know that we are dealing with someone who needs our love and care. So I would encourage you to just kind of have an understanding. And again, we don't want to cause any injury to the when I was in to the patient. When I was in this pilot project, one of the things that we came about, I put this slide up there because as chaplains, we're story catchers. We do that through listening. Because I'm running out of time, we'll just move on. We'll move on to, I'm going to skip through that case 1. Could you go to that case 2, please? 67-year-old Navy veteran. In fact, I had taken this individual's job, and at this hospital. He became very ill, had an adult son and a daughter who lived 1,500 miles away. And he felt a sense of guilt about not making timely decisions, such as taking care of his health, being available to his family when they needed him. Lots of regrets about life. He battled with his health for almost 20 years. The coloscopy bag did not accept the prognosis as his health worsened, and he wanted everything done. That's for another class, but you know, in life-sustaining care, he wanted everything done. And as his condition worsened, he entered palliative care. He delayed hospice care, this chaplain, and he was given the prognosis in palliative care of days to weeks. I visited him, this chaplain, one night in the ICU, and you know, as I stood by his bedside, he was just going on and on, just talking about, you know, I know I caused this on myself. I see a question there. Maybe we'll come back to that. He says, I know I caused this on myself, and he's just talking. But you know what I realized really soon along the way, that he wasn't really talking to me. He was speaking. He had someone present to hear what he was saying, and so I didn't interrupt him. And he spoke. He says, you know, yeah, I should have went with my son. I was in Michigan. I should have went with my son to Texas. And if I'd went there, then, oh man, I don't know how this situation wouldn't have been so worse. And you know what? I probably got sick in the hospital. And he just went on and on and on. My only response was from time to time making eye contact with him, and just from time to time saying, yeah, you know, wow. And maybe asking a quick question to let him know that I am listening to you. But I didn't interrupt him about anything that he said. And after I think it was about an hour and 10 minutes, the chaplain, he said he was tired. He says, I'm going to get some sleep now. And I left. You know, the next day, I don't remember whether it was the next day or maybe a day or so, he was moved out of the ICU, and he was now on full comfort care. But, you know, he said to me, he said, the other night when I was in the ICU and I was just talking and all over the place, you gave me the best chaplain care that I could have that I could have ever received. He says, you didn't interrupt me. You just let me talk. And he says, boy, did I needed that. And sometimes that's the best care that we can provide, is just to listen, because as you know, people don't oftentimes expect us to solve their problems. They just want somebody to process something with. That's about the time that we have really to deal with that case. Do you routinely acknowledge knowing their medical diagnosis, prognosis, or allowing them to tell you? Not routinely, not at all. If they want to tell me, but if they want to tell me what's going on with them, I certainly allow them. Again, it's being there. It's hard to say. It's just being there. I see that we may have.
We have a couple more minutes, Chaplain Brown, if you want to keep going. I would like to say that as advocates, sometimes the chaplains in a hospice and palliative care role may have to ask for an ethics consult, or ask for the treatment team to do an ethics consult. We, with the chaplain earlier that asked about the family in denial, we had a case where a woman had gone through treatment after treatment after treatment for cancer, and she had decided within herself that it was time. She was ready to go home, and by home on the other side. And her husband was very much not in that place. He wanted every treatment option possible. He wanted to look at all the alternatives, and her body was tired, her mind was tired, her spirit was tired. And so as a team, we wrestled with, what do we do? Because she wanted to stop all treatment and just move to comfort care. And he was just the opposite. And so we actually had to call an ethics consult. so that they could visit with the family, but also visit, visit with the staff and figure out what would be ethically the right thing to do.
Absolutely, yes. Thank you for that. Sometimes, yes, we do have to step aside as sometimes maybe the only individual to say this needs to go, as you said so well. Given the time that I just want to mention the bereavement family survey. Hopefully you are familiar with it, and there was a website where you could have, and I think it's also downloaded and posted for you. What I did was I went through the this one has the 20 questions, and basically, as you know, this is it's to help us to better understand the veteran's experience given through the family member, and gathering information that will help us to provide a better care better outcomes for the veteran. I highlighted a number of 1, 2, 5, 6, 7. I highlighted at least 7 questions on here that I thought that if you look at the bereavement survey and the question, it's not that we're going out with a chart in our hands to make sure that we meet these objective needs, but I think this will kind of help us to be focused on the type of care that we provide. So, for instance, question number 1 says, what about after the death? How much of the time did the staff who took care of the veteran provide you with the kind of emotional support that you would have wanted? Most of the time, that staff is probably going to be the chaplain. Nurses on our palliative care unit sometimes have the time, sometimes they don't, but the chaplain have the time as a member of that team, and they're going to remember that when they fill out this survey. So look over the survey, and then you will see how very valuable the care that we provide is, and how much it contributes to the overall care that the veteran receive. Whether we make a distinction between the pain and the existential suffering, we certainly have to, and certainly the pain is physical, and as chaplain too. Sometimes we're not medicine providers, but can I ask someone if they feel depressed, and some very depressed, have you told that to your doctor? No, I haven't. I can say to the team, the patient report to me that he's very anxious, that he's depressed. And sometimes that hadn't been considered because they have been too busy trying to manage pain, doing pain treatment and so forth. So yes, we're looking out for all the type of pain, the pain of leaving the family members, and I've always provided for him, for her, and now I won't be here anymore. All those, we are there to listen to all of that. Well, unless there are questions, I am finished, and I thank you so much, and I appreciate your time, and hopefully I was clear enough coming through it to you. I have a mouthful of junk myself. I've been having some braces in my mouth for 3 years, and I'm praying that they come out here next week. So, but
we'll pray for an easy removal for you.
Yeah, so I can. So